gather. Thank you. Okay. Okay. And oh, sorry. Do you to advance? So I just press this again. Yeah, that's forward. Oh, the green button. Okay. All right. Thanks, folks. Hope you enjoyed your lunch. I think we may have Senator Wyden, oddly enough, coincidentally enough, is doing a community forum about the opioid crisis about 300 yards from here, which is, so we may have lost some folks to that. If anybody now is like burning to go say something to Senator Wyden, now's your chance. He's right down the street. Just a quick reminder to complete your evaluation forms, says Christine. So we're going to pivot now and switch somewhat. We've talked about substance use disorders a fair bit, but we're going to pivot now and spend our remaining time this afternoon really focusing on more exclusively on substance use disorders. And we'll see intersections with pain and trauma, but we're going to view things a bit more from this lens. So what will happen is I'm going to give a brief overview. In fact, I'll tell you this right now. I'm going to give a brief overview of kind of the diagnostic criteria and neurobiologic basis of addiction. And then Anderson will come up and talk about what's really important, which is treatment for addiction, sort of helping you guys to understand a day in the life of addiction treatment, what really goes on in those process groups and rooms. So he'll orient you to the ASAM levels of care, some of those behavioral modalities, and some of the skills and tools that they use. And then I'll come up and wrap up talking more about medications which are used to assist in treatment of substance use disorders, focusing primarily on alcohol and opioid use disorders. Don't have any financial disclosures. So this is a patient of mine that will sort of thread throughout the discussion today. Arthur's been, if you've heard me talk before, Arthur usually comes along. I think he's going to retire after today. We've worked this one pretty well, but you'll see some new twists in Arthur's adventures in this talk if you've heard about him before. So I met him actually about 5 years ago. He was a new patient to me, just regular 20-minute new patient in a primary care setting, and I had some hospital records from him, and it said he had a history of alcohol use disorder, and that had resulted in a few complications for him. He had chronic pancreatitis from it. He had insulin-dependent diabetes, and he was listed as having chronic pain on chronic opioid therapy. In his chart, it said he had an ongoing history of major depression, recurrent, moderate. He had worked in the past as a sort of a computer guy, network systems analyst, but he was now unable to work due to his substance use disorder and medical conditions, and still lived with his parents in an affluent suburb of Portland. So there's a lot here about his social and developmental history and his behavioral health history. I didn't know these things when I first met him, but as he got involved in other programs, I learned more about him. Learned that he'd been raised by his parents, by both his mother and his father, till they were divorced when he was 5. His mother remarried, and he had a difficult time with his stepfather, who he reported as being angry and volatile. He wasn't physically abused, but endorsed feeling emotionally abused and alienated. He then went off and joined the Navy, was discharged after 2.5 years, and thinks his biologic father had a drinking problem, but didn't know for sure because he didn't know him that well. In terms of his engagement in treatment before, he said, we learned later that he said, I've had symptoms of anxiety since I was a child, and then started really feeling depressed in adolescence. He started then drinking alcohol and using cannabis at age 13, and then started using cocaine shortly thereafter. And actually, I didn't know this at the time when I met him, but he had been in treatment for the first time at age 18. It was a mandated treatment after being arrested for breaking and entering. Can you guys hear me? You can hear me okay? So at our first visit, doing the thing, getting to know one another, and he said, yeah, I've had a long struggle with alcoholism, but I actually was doing well. I had a year of sobriety, and then he had relapsed 3 months ago, and this had precipitated a flare of his chronic pancreatitis, and that's what landed him in the hospital. So he gets out of the hospital. That's when I meet him. He says, I've been sober for a week. He re-engaged with his sponsor. He was going to daily AA meetings. At the time, he told me, I've never been in substance use treatment before. I don't have any aberrant behavior with opioids. I just take them for my pain. He had to leave his prior PCP just on administrative reasons, so to change in insurance. And he said, Rachel, I'm just interested in staying sober, get my diabetes under control, doing whatever you need me to do. And he also needed a refill on his chronic opioids. Okay, so some of this may be review, but since we wanted to sort of give you kind of addiction 101, but for some of you this you might be at a 201, 301 level, but what are the definition and diagnostic criteria for addiction? Well, the top there is what ASAM, the American Society of Addiction Medicine, gives as the definition. And it's fairly biologically driven. It's a primary chronic disease of brain reward, or of the brain, working on systems of reward, motivation, memory, and other circuitry. And then dysfunctions in these circuits lead to a lot of other biological, but also psychological, social, and spiritual manifestations. And that's an individual who's pathologically pursuing reward and relief by using substances or by other behaviors. But there's a second definition, which is another way of looking at this, and this is by a fellow, Gabor Mate, who is a physician who does a lot of addiction work in the East Side, I forget the name of the neighborhood, forgive me, but in Vancouver, BC, where they've sort of created a community where a lot of people with substance use disorder live, and there's a lot of addiction there, a lot of addiction treatment, and that's where he practices. And he takes a broader social view that it's not just about this kind of demon molecule that gets in the brain and causes all of these diseases, that he says it's really any repeated behavior, which may be substance related or not, in which a person feels compelled to persist regardless of its negative impact on his or her life and the lives of others. And we'll come back to think a little bit more about Mate and his approach to addiction in a second. Okay, so to make this sort of interactive, we're going to have some question and answer. Well, I guess I'll have some answers. You may have better answers. But I'm just going to read some of these to you and then give you a couple minutes to think about it. So for the diagnostic criteria of substance use disorders, first question is, all of the following are criteria for the diagnosis of an opioid use disorder in someone while being prescribed opioids, except A, tolerance, B, withdrawal, C, repeated attempts to quit, D, craving, or E, A and B. Any thoughts? Hang on. So the answer is A and B. So it's accept, tolerance, and withdrawal in the setting of somebody who is being prescribed an opioid. So these are the DSM-5 criteria, which came out in 2013. First important thing is that they used to say DSM-5 with a Roman numeral V, and they've contemporized that, and now the American Psychiatric Association says we can use the number 5. The big thing with these criteria is that they've more or less been combined and actually strengthened. In DSM-4 and DSM-4R, you only needed to have one criterion in order to qualify. And here you need 2, you can see at the bottom, 2 to 3 criteria to be in mild or moderate substance use disorder. Mild is 2 to 3, moderate is 4 to 5, and severe is 6 or more. Other things that are new in these criteria is that they added craving, which had not been there before. They removed legal problems as a criterion. And then this caveat, which you might not be able to see, but for those 2 for tolerance and withdrawal, those aren't counted as criteria if they're happening in the context of being prescribed a substance for a medical condition. Hence the answer to that question. Okay, so I'm going to go back to Arthur, and we're going to use him a little bit to help us understand kind of a neurobiological framework for substance use. So I meet Arthur, and I say, well, okay, this is complicated, but we have some resources in our practice to manage this. So I refer him to our we have a kind of a combined addictions chronic pain program with full pain and functional evaluation. But he doesn't do so well. And over the subsequent 2 months, he relapsed repeatedly on alcohol. He kept bouncing into the hospital for flares of his pancreatitis. It started the hospital thinking that maybe he was drinking in order to get his pancreas to flare in order to then get into the hospital to get opioids. So they would mention that he'd specifically asked for IV hydromorphone. He would mislead staff about his outpatient doses of opioids. He'd say, yeah, Rachel gives me, I get about 240 milligrams of morphine a couple times a day, so I can't see her for a while. So if you can give me a script until I see her, and they would do that, and then they'd write these blasphemous discharge summaries about what a bad doctor I am. It really got on my nerves. So he was noted once, I saw in an ER record, that he'd crushed his oral oxycodone. He was sitting in the ED, he'd crushed it, and he'd put it into a urine cup with some water. Unclear what he was going to do with this concoction before the nurse came in and found him. When he was admitted to the hospital, he would manipulate his IV so that he would create an abscess or some thrombophlebitis, and it would cause his stay to be extended in the hospital. He could access more opioids. And so this would make people aghast. You know, you get these sort of, I did as well, angry and this kind of recoiling reaction to this kind of behavior. And Arthur's not a bad guy. Arthur has he has an opioid use disorder. And so for me, it really helped me to start to relate better to patients when I understood, I'm very mechanistic, but it helped me to relate better when I understood what was going on. And the person who really, the scientist who really helped me to understand this is this terrific guy named George Koob, who now runs the NIAAA, just a terrific addictions researcher. And this is going to look a little scary. They're going to do a little neuroanatomy. But George Koob has really boiled addiction down into 3 primary processes or circuits, and he's actually color-coded them for us. So we're going to look at, first, we're going to look at the binge and intoxication stage. That's kind of the fun part of addiction. That's the blue circuit. And then we're going to look at the withdrawal or negative affect phase. That's the red circuit. That's what Dr. Koob calls the dark side. And then we'll look at the frontal cortex, the preoccupation and craving circuit of addiction, which is the green part. And that's the part that is kind of what makes us human. Okay, where am I here? Okay, so first are the neural circuits of the binge intoxication stage. This is the fun part. This is your reward system. It's really focused, if you can see up there, in that middle structure called the nucleus accumbens. Basically the whole reward system functions within a set of brain structures called the dorsal ganglia. Primarily the nucleus accumbens, which sends projections up to the dorsal striatum and also up through the globus pallidus and into the thalamus. And you'll hear about the thalamus a lot, both in addiction and a lot in pain talks. And what happens in this stage is 2 things. So one is, different peptides, primarily dopamine and opioids, flood this system and cause euphoria, cause that sense of intoxication. But they also create this really interesting phenomenon called incentive salience, which is really more about cue-induced learning and habits. And the idea of incentive salience is it's reward pathways that are being wound up not so much because you are experiencing the liking of something, you're not having the pleasure, but it's the wanting. And so a lot of these reward systems are involved in that kind of anticipatory reward or pleasure from seeing something that might be desirable. So the reason that this is important, we'll learn about it more in terms of a treatment modality, but it also has some public health implications. There were, these big public health efforts to reduce heroin use in the 90s, and one of the images that was used were these sort of meant to be grotesque, horrifying images of people, injecting, sort of graphic images of people injecting drugs in bathrooms and syringes and things like that. And it was meant to repel people, but instead, because of this incentive salience and cue-induced learning, it actually triggered people. So we've learned not to use that. Okay. So this just shows you, it's just sort of a sense of, this is the nucleus accumbens, that little fat pink guy there in the lower right-hand corner, which George Koob calls the grand central station of reward. Everything converges here, from alcohol to cannabis, opioids, stimulants, and are mediated primarily by 2 peptides, primarily dopamine. Let's do 2 peptides, primarily opioids, which are what help with our response to pain and produce euphoria, but also dopamine, which is a really important neuropeptide in that kind of the amount of dopamine that you get helps your brain to predict reward and helps tell your brain go for it. So if we had more time, we could talk more about the intersection of pain and addiction and how dopamine circuits play a huge role in that. But anyway, just to give you a sense of what's acting there in those structures. Well, so what happens over time with addiction? And this is the dark side, right? This is where addiction stops being interesting and fun, full of euphoria and intoxication, and more moves to a withdrawal, or what Dr. Krug calls the negative affect side. And you'll notice in this diagram here, these circuits still involve the nucleus accumbens, but but the nucleus accumbens has changed color. I mean, it doesn't literally change color, but in this diagram it changed colors. It sort of moved from blue to red, and instead of projecting up into those reward pathways, it now projects down into the amygdala, right? That little, we've talked about, I think both Anderson and Thomas referenced that earlier, you know, the amygdala, that little almond-shaped structure deep in your temporal lobe, which mediates anxiety and fight or flight. And as you move through subsequent stages of addiction, you lose reward function in the nucleus accumbens, and you gain stress function with projections to the amygdala. It's this idea in your brain that there's payback when you overdo your reward system. What goes up must come down. Well, so what does that actually mean, and how does that help explain why Arthur is doing what he's doing? This is a conceptual model from a psychologist, Richard Solomon, to help you understand it a little bit better. So if you look on the left-hand side there, that's an individual, let's say, well, hang on, let me just back up a sec. What Richard Solomon talks about is this idea of the opponent process, that you have an A process that makes you feel good, and you have a B process that makes you feel bad. And on the left-hand side, in someone who isn't addicted to a substance, let's say that you go to a wedding and you have a few drinks, if you're inclined to do that, you get a nice peak in A. You get a nice peak in sort of a positive reward experience. And then A kind of tempers down. And then the next day you might get a little bit of a hangover. You get a little bit of that B process. But you pretty quickly stabilize and return to normal. But in someone who becomes dependent on a substance, look what happens. They're using, but they no longer get any of that peak of A. They're no longer getting any of that reward. And instead, what they get is a much deeper and more pronounced sensation of B, of the sort of the bad process, with a much slower return to normal. So the question is, and this is what George Kubis kind of spent his life figuring out, what causes that B process in substance use? And we'll see that it's kind of a double whammy. So what we know, Nora Volkow, who's the head of NIDA, has shown us that after repeated use of any substance, her work was in cocaine, that your receptors, your dopamine receptors, like we talked about, that help to mediate reward, neuroimaging shows that those go away after 4 months of cocaine use. And basically the idea is that you start to lose all of these happy peptides that help keep us balanced, euthymic, and the absence of those just alone makes you feel lousy. So the absence of dopamine makes you feel dysphoric. The absence of opioids give you pain. You also have other helper neurotransmitters like serotonin and GABA. The absence of serotonin causes dysphoria. The absence of GABA makes you feel panicked. But the cruel thing about addiction is that you not only have sort of the loss of the good guys, but you get the emergence of these bad guys. There's a whole new class of what Dr. Koob calls the anti-reward neurotransmitters. And these you start to see upregulated and activated in people who have prolonged addiction. So there's one called dynorphin. I'll pause and tell you a funny story about this, which was I was telling Anderson I had to give a talk about this to 200 psychiatrists, which was like the most intimidating thing in the world. And then some question and answer, and a woman came up in this thick German accent, which I can't really impersonate. She goes, "What is dynorphin? What is it? Has structure? It has what?" And I, as a person of Jewish heritage being interrogated by a German psychiatrist, I cried And I said, I don't know. So I've read a lot about dynorphin in the meantime so that I don't go through that again. And we can talk more about it. But it's basically, it's in the opioid family, and it's kind of it's like the anti-opioid, and it's upregulated during withdrawal and causes profound dysphoria. There's also corticotropin releasing factor, CRF, which we know drives our stress response, and norepinephrine drives stress response. And these are all activated in your amygdala and ventral striatum during withdrawal. So finally also is, well, we're these highly evolved mammals, right? We have these big heads and these big frontal lobes. And can't our executive functioning, our prefrontal cortex, help us to make decisions that override this limbic system, that amygdala that's kind of run amok? And basically the answer is, well, it's hard. I mean, those are all those structures there in your frontal cortex, but they start to function poorly. They don't function well. And executive dysfunction causes impulsivity, compulsivity, sleep disturbances, which further perpetuates executive dysfunction, and impaired decision making. And the process by which this happens is kind of a vicious cycle, where you have this initial intake, which causes this initial impairment of executive functioning. So then you make a bad decision. You say, okay, I'll use a little bit more. That causes neuron death in the frontal cortex, which then causes more lasting prefrontal cortex abnormalities and hypofunction, and that causes further impairment of the executive functioning, and the cycle kind of continues. So what happens then in somebody with addiction is you find that their overall hedonic tone, their overall sense of well-being in the world is really radically altered. And this is a diagram from George Koob to illustrate that. And at the top, you have this idea of a good sort of homeostatic mood, right? So homeostasis being this idea where you have kind of a good physiologic equilibrium. You have a normal set point there in the middle. You have a wide dynamic range. There's no pathology. But you'll hear a lot of not just addictionologists, but also developmental psychologists, people who are trauma experts, talk instead about this idea of allostasis. Allostasis being this kind of dynamic process where your body and your mind are trying to adjust to an environment of stress. And that's what happens with addiction. You're sort of, instead of having this nice set point that's regular, your set point gets lower and lower. You have sort of a pathological range. It's erratic, it's unpredictable, and you see that your set point sort of your mood and your tone gradually lowers and lowers. And so when I think about Arthur sitting there in that ER bed crushing oxycodone or saying, my doctor gives me these medications, it's because he's living down there. So I'm going to turn it over to Anderson here in just a second, but I want to pause for a moment and talk about another side of addiction, which I won't have a ton of time to describe. But this model sort of speaks to the idea that this is all aberrance, right? It's all pathophysiology. It's all everything gone wrong. And then I met, where are you, buddy? So then I met this guy on your left, whose name is Darren Ford. He's an addictions counselor here in town. He works at OHSU now. He's worked in a number of places. And he introduced me to the work of Gabor Mate, who we spoke about earlier, who's there on your right. Darren tells this really funny story that he met Gabor Mate, and he said, "Can I have a picture?" And Mate said, "Okay." And he said, "All right, let's smile real big." And that was like the biggest smile. That was really funny. So, but what Mate kind of opens up our eyes to, and you've heard about this a lot already today, but how much our early childhood, how much different experiences in our childhood radically change our neurobiology. And this is from Mate's book, In the Realm of Hungry Ghosts, where he talks about the people that he works with in the Central East Side. And he says, "We know that the majority of chronically hardcore substance-dependent adults lived as infants and children under conditions of severe adversity that left an indelible stamp on their development. Their predisposition to addiction was programmed in their early years, and their brains never had a chance." And what Darren sort of opened my eyes to, and I think this is what Lydia spoke about earlier, is that these are people for whom they don't feel at home in the world. They don't feel like they have that kind of normal physiologic set point. And they're trying to get a sense of attunement or resonance or being at one in the world, and substances help them to do that. So instead of this all being viewed as pathophysiology and aberrancy, in some ways you can see it as and I take this with a grain of salt, but it's kind of a normal response to a highly chaotic environment. And I won't talk about this too much, but this is a diagram of how PTSD works. I've got this diagram when I was in medical school, and basically the idea that under trauma, your brain stops sort of using its, when your brain is releasing corticotropin releasing factor, its usual stress peptide, rather than sort of moving to the left to the creation of steroids, which is what CRF is supposed to do, that axis ultimately is shut down, and instead it shunts over to the amygdala. So it really struck me when I first learned that really the pathophysiology of addiction and the pathophysiology of trauma are really exactly the same. So how's Arthur doing? Well, he returned to see me in clinic after multiple hospitalizations. He was on this big bender. And when I saw him back several months later, he said, well, I was only drinking so much because it helped me manage my pain when I had no opioids. And along the way, he had, his mother had died of brain cancer. His father had had a massive stroke. And so he lost his housing and was now on the street. And he said, yeah, I haven't had access to any opioids for several weeks. I've been drinking pretty heavily. And he said, no, I don't think I need to go to detox. I don't need medical detox. But Rachel, if you could just give me some Ativan for a few days, that would help me detox on the street. And he said, will you help me just this one time, just to get me through? So I sent him to Anderson. So I'm going to pause there. We're going to leave Arthur for a bit and turn it over to Anderson, who's going to give you a lot more information about addiction treatment.
Hello again. This is the other ones I did not do 2 talks. I'm setting my timer. Bear with me. But this time, here we are, for better or for worse. After the Q&A, I'm going to be doing a one-man version of West Side Story. If you want to stick around, just feel free. Thank you for the great info to kick this off. Poor Gabor. Vicarious trauma, perhaps? I don't know. But I don't know if he still does, but he works with a tough population. It's a great book, In the Realm of the Hungry Ghosts. People read that book? They're ringing a bell. Do we know what that title's in reference to, Hungry Ghosts? Yeah, the idea of the hungry ghost, which comes out of Eastern philosophy, and the ghosts whose appetite can never be satiated, right? Many times they're portrayed as having tiny mouths and giant stomachs. Kind of interesting. So that's me. I'm going to talk to you about the basics of treatment, sort of a treatment 101. And I asked earlier who were behavioral health providers, who were specifically in addictions treatment. Show of hands. Oh, that's a fair amount of people. Okay. So some of this, I'm guessing a lot of this won't be news to you. So maybe it will. I don't know. Let's dive in here, shall we? So treatment, this idea of treatment, it's a very well-known term. I would imagine that when you hear that word, everybody in here has a different perception of what treatment is. Perhaps, maybe you've had personal experience with it. Maybe you've had a family member go through it. Maybe you've seen it on the TV, right? There's some treatments popular. What are some of the shows? Celebrity Rehab with Dr. Drew. Anybody ever see that one? I don't mind Dr. Drew, but I can assure you that in no treatment center I ever worked in were people allowed to sit by a pool and have their cell phones. That just wasn't part of what was in the normal day-to-day process there. There's also intervention. Has anyone seen intervention? Right? I'm always amazed at the number of my patients who would watch intervention in their addiction. It was like one of their favorite shows. You did that? See? There you go. Right here. We have direct experience with that. So what is treatment? Well, like I said, it kind of varies to everybody. So it's not uncommon for us to get phone calls at our clinic from the concerned loved one that says he or she, or they for that matter, needs to go to rehab right now, right? And we frequently get these phone calls Friday afternoons at 4:30 p.m. as we're getting ready to close for the weekend as an outpatient clinic. Some of you can relate to this, I would imagine. And then there's the concerned patient who says, I need to go to rehab right now. Not, I know there's a process. I know there's an assessment process. I know I need to have a diagnosis. I'm hearing all that, but I need to go now. Okay. So the other interesting thing is sometimes I'll just be describing our services to new patients who are being oriented, and I'm talking about the different levels of care, and I even mention rehab, and their eyes get really big. And I can tell by the person sitting in front of me that they probably don't need residential treatment, right? Just a hunch. And I said, no, it's okay. I'm not we're okay. I'm not going to send you to that place, right? Rehab. And then just for the kicks of it, there's a great Amy Winehouse lyric. They tried to make me go to rehab, but I said, no, I'm not going to do that, right? And so there we get into motivational interviewing and working with families around how do we get somebody primed and interested and motivated to go to treatment, right? And the stages of change comes into play with that. So I'm going to take you through some basics so you have a better understanding of what we as treatment professionals look at and what kind of grid we put people on in terms of placement. This is, ASAM's been mentioned, so the American Society of Addiction Medicine. We have an agreed upon standardized approach. So before any treatment can occur, a full biopsychosocial assessment must take place. Okay? So biopsychosocial assessment. So what that means is that we're gathering data across 6 dimensions. So your counselor who works in an addiction setting is going to be doing this. Okay? And so dimension 1, we're assessing acute intoxication and withdrawal potential. At the clinic where I am, there's a medical team there who I can conveniently go down the hall to and say, hey, I need some help with this person. They're visibly shaking or whatever's going on. Okay, we also may send them to our residential unit for residential detox stay, and they may complete that and come back out and do outpatient. But we need to look at that. Dimension 2, biomedical conditions and complications. Of course, we want to take a look at that. Dimension 3 is emotional, behavioral, or cognitive conditions and complications. So there you're getting mental health history and medications and thoughts of self-harm or suicide, abuse. It just goes on from there. That's where you'd find your mental status exam, for example. Dimension 4, we want to actively assess somebody's readiness to change. Okay, so that's where you see some of the motivational interviewing coming into play. So questions like, on a scale of 1 to 10, how concerned are you about your substance use? What do you think are the pros and cons? These are the ways we tease this out. And Miller and Rolnick's book was mentioned by Lydia. There's a lot of great ideas in there for how to frame language and have those open-ended questions and get potentially, it also brings clarity to the patient, right? They may hear themselves saying change talk that they haven't said before. But we need to assess that because that's a factor as well. Dimension 5 is relapse, continued use, or continued problem potential. Right? What's their history? Have they ever tried to get clean before? What's been their longest period of sobriety? How did they do that? What kind of supports did they have in place? We really want to flesh that out. And then Dimension 6 is the recovery environment, looking at things like employment. Do they have a driver's license? Do they have any military history? What's their family situation like? There's a family genogram, and really trying to assess what is going on there, because some environments can be extremely high risk, right? You may do all this great work with somebody in treatment, and then they go home, and every single family member is smoking marijuana 24/7 or abusing opiates or whatever the case may be. So we want to assess that. So what is this? Is there a DSM? Yeah, so we want to ask that question. Based on all this data that we're gathering, is there a DSM-5 diagnosis that was just mentioned, right? And we want to arrive at that. So an example, alcohol use disorder, mild, moderate, severe. So once we've determined that, there's a continuum of care. So patients enter treatment at a level appropriate for their needs, right? And we step them up for more intense treatment or step them down, right, if they need less treatment. ASAM says that if people are, a lot of people sort of fall in between. ASAM says you want to put them in the lowest level of care that's clinically appropriate, okay? So again, family members may feel like they got to go to rehab, and there may be some benefit there, but if you can justify putting them in intensive outpatient, that's what a clinician's probably going to recommend, much to the dismay of some family members. So it gets, some of those discussions get a little bit sticky as far as what a patient or a patient's family wants and what is being seen clinically. Or, the clinician is basing it off patient report. So that's important, right? So I'm hearing this. This is what I'm being told. I suspect there's more going on, but, I have to go by the data, And sometimes I get a lot of extra information from family members, but I have to go by this encounter with the patient, right? And you can get creative with that, though. I think that's one of the interesting challenges as an assessing clinician is how do I start to form that relationship? And language is an art form, right? And how does that reveal more in a way that feels safe to them? Because there's many things that are diagnostic that people don't want to admit, right? There's a lot of shame that comes with this territory. So just roughly speaking, you could look at the ASAM book. It's really thick. I don't recommend it unless you have to. It's not the most exciting read in the world, but roughly speaking, we've got 3 levels of care to keep it simple. Level 1 is the lowest level. We're saying 1 treatment encounter per week, okay? We have some people, for example, who are on Suboxone with our services, and they're doing so well they come in for less frequent check-ins, right? And there's some patients I see once every 6 months just to check in. How's your medication going? They're very stable. Level 2, we're looking at intensive outpatient treatment. These are about 3 to 5 encounters per week, okay? So that means they're coming into a group and educational groups and process groups, maybe punctuating that with individual sessions and treatment plan updates. IOP is a specific level of care. And then level 3, we're looking at residential or inpatient treatment. And I put 2 weeks to 1 year. That's quite a range, isn't it? Very broad range. Here at Kaiser, we have what's called Brookside, which averages about a 2-week stay. Sounds pretty short, but all the curriculum is it's dense, and a lot happens in those 2 weeks. And if people tend to stay beyond 3 weeks, let's say, it really becomes redundant. And so it's modeled to be very short-term residential treatment to achieve stabilization, and then we have robust outpatient treatment services available to them where we then wrap around them. That's our approach. In the beginning of my career, I worked at DePaul treatment centers. I have a special place in my heart for DePaul. Anybody familiar with DePaul treatment? That's much longer term care, and I had that experience as well, where it's more of you start to get people back into society. They're there for a long time. There's a lot of behaviorism at DePaul, and that if you do well, you get a pass, right? And that's great. People really want to work for that. Or you get to go to outside meetings, for example. We'll give you a pass to go to Voc Rehab or whatever else is going on. So there's a lot of value in these different lengths of stay. And if your Promise is in Malibu, is that where Promise is? What's that? Passages, that's the one. I'm sure, I can't, anyway. There could be some benefit to keeping somebody there as long as possible. I don't know for sure. But residential treatment, this means you live there. It's pretty straightforward, right? And so in residential treatment, people have a list of things they can bring or can't bring, and their bags are usually gone through to make sure they're not smuggling anything in, and every facility is going to be a little bit different in that regard. You may need detox before you go to residential, right? So you got to get stable, of course. You want to mitigate those health risks and then move forward. A number of the residential treatment centers, specifically the 2 I worked at before Kaiser, now have detox services on site. It's pretty cool. DePaul, and then I was out in Columbia County at Pathways. So what are we doing in residential treatment? Stabilization is a big piece of that. helping somebody find more acceptance around this diagnosis that they're carrying, okay? Helping them to normalize it. You know, let's name this thing so we can treat it, right? Skill building begins there. Becoming relational is really important about residential treatment. So it's called the milieu, okay? It's this sort of living organism of a large milieu of folks. It can get pretty interesting, the milieu dynamics. We don't call them rehab romances for nothing, right? They do happen. True love is found there, and if you can imagine, it usually works out. Okay, that's a joke. It's a joke, right? I mean, what a great dopamine hit when you're newly sober is, you know, sex or intimacy or the thrill of being desired. When I was at DePaul, there was a famous client who'd earned the name of Spider-Man because at the DePaul building, there's a courtyard, but the courtyard stops at the second floor. So if the men were on the third floor, so he would tie his bed sheets together and he would scale down the wall to go in his girlfriend's room on the second floor. So he earned the name Spider-Man. It's very creative. Those are the things that can keep you going in those environments sometimes. So that was something that always was interesting to watch, those dynamics. And then the other thing that you may be focusing on in residential treatment is housing and job skills, which I mentioned. You know, that can be a real challenge, you know. I mean, someone's coming into residential treatment to stabilize, and they're homeless. You know, I mean, DePaul, for example, is great in that it's able to access central city resources. And you know, there's a lot of sort of behind-the-scenes ways of people getting their needs met because the people who work at these agencies, a lot of them know each other. And I'm not saying there's anything wrong with that. It's like, you know, I got a clear pathway. Like, we can call so-and-so, and we can maybe get you on some kind of waiting list. That can be a real challenge, though, to find housing. Clearly, the city of Portland will give you a tent, but how do we find housing for people? That's a frustration of mine, but I won't get into that. So in residential treatment, you've got individual therapists. They're doing treatment planning with you. You got to have a treatment plan. What are we doing? What's the problem? What's the goal? What are the steps we're taking? Ongoing assessment of needs. So residential treatment is a rich experience. People change quickly. You mentioned, Melissa mentioned Suboxone. You know, get somebody on Suboxone, and like all of a sudden you're talking to another person in a day. And all of a sudden there's a changing assessment of needs and priorities, and people become more clear. You're trying to integrate some of these skills that they're learning. You may be doing some case management work, coordination with the treatment team, so many times the individual therapist is advocating for their patient, right? Because there's that relationship that's there. And you may be coordinating with the family also, having family sessions, looking at boundaries, expectations, etc. There's two different kinds of groups that happen in treatment. There's educational groups and there's process groups. Education, you may be learning about alcohol and drug and relapse prevention, some of the modalities that I mentioned earlier, DBT, CBT, mindfulness, stress reduction. You can really get into some basics of diet, sleep, daily living activities, co-occurring education, family education, right? That's really important to arm people with that knowledge. And then you've got this group therapy component. Now, many times group therapy is portrayed in the media as this very sort of in-your-face, has anybody seen that portrayal of therapy, right? Or group therapy is this really, I don't know. Media usually doesn't get it right. They sort of make caricatures of it. Group therapy, what I've seen as the most effective modalities, are very process-driven. In other words, as a group therapist, you're tasked with involving the entire group into the discussion, involving each group member in some kind of relational feedback piece. Many therapists fall down the rabbit hole where group therapy does turn into one-on-one treatment. I got 12 people sitting with me, and I've been dialoguing with you for a half an hour. And what starts to happen is people start to fall asleep. So my little plug there for good group therapists is you really want to keep it process-driven in the here and now. And the primary tasks of group therapy from a process standpoint are recognizing that talking helps, right? People, like I mentioned, there's a lot of shame. But how do we get people talking and discussing the issues and challenges that they have going on? Group therapy helps people decrease isolation. There's that becoming relational piece. They can identify new problems. So if you are talking about what's going on in your life, I mean, the lights are going on all over the place, and people are saying, oh, right, yeah, I've got that too. I hadn't even thought of that. You know, we only see what we see, right? And I think the challenge of working with people's egos is the belief that, oh, I got this. I'm seeing everything I need to see. You know, the client who comes in who says, I've been to 10 rehabs, I could teach these groups. Those are the ones that scare me the most, right? Because that's a set of blinders, you know, that can be really dangerous. How do we help people stay open and identifying new problems? And also I think group therapy is a place where people can get that reality check. You know, therapy has changed in that it's, at least my exposure, it's way less confrontational and in your face. First of all, that's not the best way to cultivate the therapeutic relationship. There is a place for straight talk, but you got to kind of gauge that. But boy, I'll tell you, group members, you watch them give each other a lot of very upfront feedback. And that's one of the interesting things as a group therapist. It's almost like the group can get away with saying things that you can't as the group leader, because there's a built-in hierarchy, whether you like it or not, and that's an interesting dynamic in groups. Where addiction thrives is in secrecy, shame, isolation, dysfunction, chaos, pain, idle time, cognitive distortions, etc. That is the little petri dish of addiction. So all of these modalities and approaches are attempting to counterbalance this stuff. Okay? Make sense? So prior to discharge from residential treatment, we're looking at a clear and specific plan. This is important. This is basic. Relapse prevention planning. So what are the specific skills identified? What skills is the patient connecting with? They're going to learn 50 of them. You know, if you do a week of DBT, you've got it's like 52 card pickup, the amount of skills that you learn. I would usually focus in on what are the 2 or 3 that really speak to you, right? Let's talk about those. Ongoing support and community meetings. What are they going to do after they get out of treatment? Okay? Now that they've learned to become relational, how are they going to cultivate that? Treatment's finite. It doesn't go on forever. So what are they building parallel to treatment that is replicating those same relationships? And I'm always pushing this point with people. I know you're close with your therapy group. That's really important. It's going to end. And you may stay in touch, but you may not. So let's use these skills out in your community, right? I'll say more about some of the options for that. Identification of triggers and warning signs. This is really important. Everybody's got their own constellation of triggers. Depends on drug of choice, environment, all that good stuff. And also warning signs. Those can be really observable externally, right? Or they may just be internal warning signs. What's going on with employment, school? What kind of follow-up care is going to happen when they leave residential treatment? Am I coordinating with these other professionals? And then what about self-care, relaxation, fun, leisure? That's an important piece of a relapse prevention plan. It's not all blood and guts, you know. It's also how are you going to take care of yourself? And that comes back to my earlier talk around resourcing. And how do we give the nervous system those things that feel good? Because I can assure you that a lot of people who are getting newly sober for the first time, guess what one of the biggest triggers is for people? Happiness and joy. Has anybody ever seen this, you treatment providers out there? It is a really uncomfortable feeling to all of a sudden feel like things are coming together when most of your life has been chaotic. Because even though that's a really crummy swimming pool to be swimming in, you know where everything is. It's familiar. And then you're going to say, oh, I'm going to go swim in this new pool. Here's the other thing about getting your life back is it comes with responsibility. And the thing about being invested in caring about something is that you could lose it. Right? That scares people who are new in recovery. Not everybody, but that's its own process. And for people who don't necessarily have any experience with it, that can be a hard thing to wrap your mind around. Oh, what's wrong? Everything's great now. It's like, well, everything being great isn't so great. You And there can be a strange magnetic draw to go back to that place of chaos, okay? It's, on the one hand, very illogical, but it also makes a lot of sense. It all depends on the lens you view it through, okay? Also, looking at medications, this can be really important, especially with co-occurring issues that are going on. So I'm going to have to read this. I meant to trim this down, but I didn't because I'd used this one before. This was a patient that I worked with, a 38-year-old male who was asked about residential treatment. He said, "It gave me a safe and structured place to go through withdrawal. It gave me the first glimpse of myself sober, the good and the not so good that I had had in over a decade. I went into residential thinking my only problem was an addiction to meth. I came out convinced I was an addict. For example, I never even entertained the idea I was an alcoholic until I did a drug use history assigned by my counselor. That assignment was mind-blowing in general." So there's a lot of education that he mentions, a relapse prevention class. The difference between suffering and clean pain, ringing a bell, right? Sore but safe. Or between feelings and thoughts, sound and simple, obvious enough, but they were radically new to me. You know, one assignment this person did was 10 insane behaviors, right? Things you did in your addiction that you wouldn't have done sober. That was illuminating for this person, okay? Residential treatment also gave me a first taste of what it means to follow direction, trust in my counselors and guides, and connect to other addicts or people with issues. That's a huge one, right? To surrender. Now, this is a very type A person, incredibly accomplished in a myriad of ways. This is a very high-functioning individual, and for this person to surrender to the recovery process was huge, and he remains surrendered. He's an amazing example of someone pursuing recovery. It's been a joy to see. The challenge of early recovery is that, in general, right, we can all relate to this. Life is full of problems. Sometimes I like to pretend that I've got them all solved, and then another one pops up. That's frustrating. Addiction creates many more problems, right? So people don't come into treatment because everything's working, everything's going great. It's a good day to go to treatment. Sounds like a wonderful idea to me. I got nothing better to do. No, there's like big gullies and ditches and debts, and I can't tell you how many patients I've worked with who haven't opened their mail for a year. All right? Early recovery means dealing with all of these problems without numbing out. So you got a compounding of problems, and then you're telling me that I need to face all of these without my usual crutch. Right? That is one of the reasons we say that first year of recovery is so important, because in addition to all of this going on, the brain is trying to heal and get back, and all that physiology stuff we've been talking about today. So other challenges, cravings, that's just basic, right? Letting go of old friends, that is a huge one. That social engagement and that social circle is giant. For our population who are facing addiction in their early 20s, especially if they grew up here and they have friends all over their neighborhood, that is really tough. That's a tough one. Physical pain, broken relationships, financial wreckage, boredom, anxiety, depression, surrender, past trauma, PTSD. We can keep going with the list of challenges. So it almost looks like a Gary Larson character, doesn't it? The woman. So I love this picture. So sober, in the mindfulness world, sober stands for stop, observe, breathe, expand, respond. It's pretty nice, right? It's got a nice flow to it. I like the other definition of sober. Son of a bitch, everything is real, right? And that's what sober can feel like. The world is in this like technicolor now, okay? And there's stop, observe, breathe, expand, respond. Okay, so, and that's what it can really feel like for folks too. I'm just kind of hanging on. I'm being whipped around in circles. So next, let's go to this next level of treatment, level 2, intensive outpatient. So how is it different? What's going on there? And I like Russell Brand is an interesting spokesperson for addiction because he's just ridiculously transparent. He really has no shame, actually, but I think there's a place for that. But he was good. He was friends with Amy Winehouse, and I'm familiar with these people's work, but I'm not like some huge fan. But it seemed pertinent, And what was so painful about Amy's death is that I know that there is something I could have done. I could have passed on to her the solution that was freely given to me. Don't pick up a drink or drug one day at a time. It sounds so simple. It actually is simple, but it isn't easy. It requires incredible support and fastidious structuring. So think of the DBT, the dialectic, the paradox, right? That's a paradox because it really, on one level, is as simple as if I don't put something in my system, I'm not going to get loaded, right? There's like an old school like AA slogan that the old timers say, put the plug in the jug, right? And there's a lot of great truth to that. You got to put the plug in the jug. But there's also this incredible process of support and structuring that needs to be in place to support that effort, okay? If people could just decide to be healthy, they would. So again, Russell Brand, we're going to go with the Russell Brand theme here. There he is in his addiction. And he is a almost unsettling bright light now. So here's another quote from my dear patient about intensive outpatient treatment. And it's, well, obviously it provided a safe space for months. It took for my emotions and brain to calm down and to engage many of the issues and problems that have fueled my using in the first place. So we start to hear more clarity coming. It taught me what it means to be honest and to value and respect the honesty of others, to let everyone have their own process and honor that. So there's some patience starting to develop there. It has been the most thorough schooling in addiction I can imagine. Every day in group brings a list of lessons about how this disease works, the different forms it can take with different drugs of choice or different people, the unique challenges addicts face and the skills they can use, and the stages of addiction and recovery. It provided needed structure and a more directly engaged process than 12-step groups, though I think those groups were absolutely necessary for developing community, finding support, and rebuilding a new way of life. So this patient really embraced both. A great example, again, of diving deeply into intensive outpatient and diving deeply into a 12-step community and holding the differences and honoring both, right? Because the worlds are a little bit different. They're the same on some levels, but they're also different. And, you know, he got a lot of lessons about what not to do in group. That's one of the great things about group. It may carry a little bit of tragedy to it, but there's a lot of lessons there. So we're looking at 3 to 5 encounters per week. We have 2 intensive outpatient programs at the clinic that I supervise. We have a morning program and an evening program. There's education and process. Again, more individual counseling and treatment planning depending on the need. Integration of recovery efforts with daily life and consistent support and structure through changes. And those changes are going to keep on coming. Right? I'm returning to work. I'm returning home. All of a sudden, I'm realizing my marriage is screwed up. All of a sudden, I'm realizing I want to do something different. Maybe I need to go back to school. Life happens, right? The other big piece of recovery that's asked is that there's an integration of community supports. Now, there's an interesting relationship between treatment. I thought you were raising your hand. You're doing that stretch. That very nice. How's everyone doing after lunch, by the way? Those negative hedonic effects, I'm experiencing that from the chocolate. That thing was a powerhouse of sugar. More than I'm going to need to go to one of these meetings maybe. It's pretty addictive. So let's see if people can name what these different community support groups are. Anybody want to give it a shot? You don't have to name them all. You can shout them out. Huh? Alcoholics Anonymous, Narcotics Anonymous, Marijuana Anonymous. I got prizes up here. It's a chocolate tart. That's my prize. Cocaine Anonymous. How about CMA? Do we know what? Crystal Meth Anonymous. Yeah. There's a lot of coffee and leg shaking at that meeting. I'm a treatment provider. I can make these jokes. HA, Heroin Anonymous. How about GA, Gambling Anonymous? You all are good. How about, actually it should just be DA, not DAA. Dopamine Anonymous? I love it. That's like the umbrella. Welcome to Dopamine Anonymous. I would be in that today. Debtors Anonymous. Debtors Anonymous. Anybody know there was a debtors program? It's powerful. Imagine that. Buying things online is addictive. Amazon or whatever the case may be. There's a whole dopamine reward system around purchasing. SAA? Sex Addicts Anonymous. How about SA? Sexaholics Anonymous. It's rich. And there's also SLAA, which is Sex and Love Addicts Anonymous. And believe me, these all have different spins on the way the 12-step model is presented. Smart recovery. Anybody heard of smart recovery? Huh?
Not religious 12-step.
It is, well, you're close. It's not 12-step, and we would say there's no spiritual component. Yeah. Which you raise a good point, because we would for 12-step programs, what we reflect back to people is, yes, there's a spiritual component to these programs, but they're not religious programs. Does that make sense? Because, yes. What's that?
We also have one of the largest atheist and agnostic AA communities in the nation here in Portland.
Yeah. And there's meetings, right? The sort of the atheist meetings that are out there, which is, I think, so cool. There's really a spot. I mean, there's a chapter in the AA Big Book called We Agnostics. I mean, most people who are coming into recovery don't have a lot of faith and hope in much, okay? So that's a really important piece. And that's great. And of course, it's here, right? Here in Portland. SMART is based around a lot of cognitive behavioral therapy. There's a psychological piece to it. They don't necessarily have clean sober dates and sober anniversaries in SMART. It's smaller, but it is available, which is great. There's Alcoholics Victorious and Celebrate Recovery, which are religious-based 12-step programs. There's WFS. Anybody know what that is? Women for Sobriety. Yeah, very good. Women for Sobriety has, I don't know if it's so much steps, but sort of there's numeric principles, and the language is more about empowerment, right? And a lot of women are drawn to that because the language feels empowering, okay? So there's a small community. Then there's Refuge Recovery. Anybody know Refuge Recovery? It is Buddhist. It is Buddhist, and it was founded by Noah Levine. I don't know if you're familiar with Stephen Levine, but he's a famous Buddhist who did a lot of work around death and dying. And his son Noah wrote a book called Dharma Punks, Punx. And it sort of was a very interesting way of introducing meditation and Buddhist principles to counterculture. Noah's covered in tattoos, very wholehearted practitioner. But he founded Refuge Recovery, which gave people a way in to organize meetings. And that's growing in town also. So there's a lot of ways, a lot of options. These are all road tested by other people, and many of them are growing, which is fantastic because, you know, there needs to be more than one option, which is great. So I just want to give you a quick diagram that shows what an intensive outpatient treatment group may look like. So let's say it's a 2-hour group. You have 2 leaders. They face each other so that they can communicate non-verbally, right? Keep an eye on each other, perhaps. You got 2 group members who just relapsed, okay? You've got 3 group members who ask for time because they have something pertinent going on that they feel they need to talk to the group about. And then you have 4 group members who are observing all of this, okay? So as you can imagine, in an outpatient treatment setting, and there's something, this person's out of medication. Excuse me, I forgot to pull them up. So they're pulling on your shirt going, hey, can you talk to the med team for me? Oh my God, I don't. And so the reason I show this to you is because there's a lot to hold and balance in a group of this size with this many presenting issues. I find it fascinating. I always enjoyed that work. Group therapy is not for every counselor, right? It can take a turn quickly. And then let's go. So moving on to the next level of care, we've got level 1 outpatient treatment. Again, 1 encounter per week. These are for patients who have more stability or as they've ramped down the levels of care. All right. Group education and process may continue. Many times it looks like more just sort of ongoing individual sessions. So a lot of people will wrap up group, and then I'll continue to see them individually for a period of time. Okay. So this should look familiar. I already talked about this. Mindfulness, paying attention in a particular way on purpose in the present moment without judgment. I bring this back up because it ties into a different sort of mindfulness approach that we see in outpatient. Certainly at our clinic, we have a group that's called mindfulness-based relapse prevention. So certainly inspired by the work of John Kabat-Zinn, a gentleman named Alan Merlot, Sarah Bowen. Alan's since passed away. But this is a way of working specifically with relapse prevention using mindfulness skills. So it does integrate cognitive behavioral relapse prevention skills with mindfulness meditation practices. This is an aftercare group, and it's experiential. So this is where people are practicing these skills. So what are they working on? How to sit with discomfort is a big part of what would happen in the MBRP group. So working with triggers and cravings, right? So many times people start to get a craving. And, well, think about it. Is there anything that you all crave? Yeah. How about, chocolate? Yeah, see, there it is. You've got the demon cake. How about coffee? Any coffee drinkers? Yeah. So what's it like in the morning for you? I mean, it's like one of the first things you do. If you're a good coffee drinker, it's the first thing you do. So that's a craving, right? Or how about any past cigarette smokers in here? Yeah. So that craving, right, is a feeling that can be really uncomfortable. And what stops the feeling? Doing it, right? Doing it, smoking the cigarette, drinking the cup of coffee, and then we ramp it up with other drugs of abuse, etc. So MBRP would have people really try to sit with that feeling in the here and now. Not too dissimilar from the pain we were talking about in MBSR. Discomfort. How do I sit with discomfort, right? And then there's other ways that expands that can really, I think, deepen people's relationship with their internal states. Did I skip one? I was listening to my phone go off. Okay. I love this Viktor Frankl quote. Anybody know who Viktor Frankl is? Man's Search for Meaning. Does that ring a bell? Anybody ever read that book? First half is about his time in a concentration camp, which is fascinating and horrifying. And then he founded a form of therapy. But I love this quote by Viktor. Between stimulus and response, there is a space. And in that space is our power to choose our response. And in our response lies our growth and our freedom. So in that space, we want to try to widen that space for patients who are in treatment, right? MBRP and other things are just one way that we try to do that. Other ideas we explore in that group are automatic pilot. That's what we call, I must have this thing, I must have this coffee, I must smoke this cigarette, right? I must buy that. That's a really good deal, whatever the case may be. That can be called automatic pilot. It's also that phenomenon of you've driven a few miles and you can't remember it. Anybody? Not that anybody texts and drives in here, I hope not. That phenomenon is at work there too. Accessing the here and now of experience, so how do we show up, right? Acceptance and skillful action is part of that. Mindfulness in high-risk situations, self-care and lifestyle balance, and then home practice. In our MBRP group, they actually do a whole yoga routine one night, right, to get into the body and have that experience. And then there's a home practice assignment. Our clinicians give out CDs with guided meditations and other home practice tips, okay? So treatment is complete. Now what? Right? Continued growth and development, working on a balanced lifestyle. Hopefully there's some kind of community support in there. And it doesn't have to be the things I mentioned. Some people find it by getting back to their churches. Some people find it in like a sober baseball team, whatever the case may be. Maintaining a day-to-day recovery program. And then, a big piece that I see with folks who are the most successful in recovery is they've adapted this idea of service, right? They're giving back in some way. In a formal 12-step process, that looks like sponsorship or having a service position, giving your phone number to the new person who's suffering. But there's many ways that people can kind of engage in that service. And that is a real salve for a lot of pain, right? People can find a lot of hope in that. So I asked my Kaiser patient, this same guy, the biggest challenge in early recovery is, he wrote, staying focused, making it through the emotions and the confusion, and also being told again and again, more will be revealed. Has anybody heard this slogan as it relates to recovery? People tell other people that all the time. I'm freaking out, blah, 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 blah. More will be revealed. More will be revealed, right? And it can drive some folks nuts, but it really has a lot of value. It's another version of one day at a time. One day at a time. No, you don't have to stay sober for the rest of your life. That sounds heavy, doesn't it? Do you want to hear about anything you can't do for the rest of your life? No, you just have to get through today. It's a day at a time. In meetings, they have all these slogans up that drive newcomers crazy because they're so kind of simple, like think, one day at a time. They're kind of gooey cliches. And then invariably my patients tell me they all mean something. Like they mean something to me now. It's pretty cool. Margaret Atwood writes that every habit he's ever had is still there in his body, lying dormant like flowers in the desert, and given the right conditions, all his old addictions would burst into full and luxuriant bloom. So what does this mean? This relates to the stages of change, being in a maintenance stage of change, right? I call it the sleeping giant, and I tell my patients this. You're not fixed, you're not cured, but you're in remission, right? The giant has gone to sleep. And that requires maintenance, right? And if you start kind of kicking it a little bit, it'll start to wake up. And next thing you know, people are back in that space, okay? And I love this quote because it's really true. So that's the frame I put around it for folks who are leaving treatment. I think I'm probably out of time, aren't I? That may be my last slide. That is my last slide. Thank you. And I'm going to turn it back over to Rachel. I think we'll be doing some Q&A together if there's any questions that come out of that. Thank you.
Okay. So we are on the